All right, let's dive into our first study, which is POLARIX trial. Polatuzumab was approved in April 2023, and since its approval, it has been up for debate. Whether should we be using this medication in all comers versus non-GCB patients only, or rather reserve this for second line? At ASH 2024, we saw an update on POLARIX. Pallawi, could you please walk us through the study design and its findings? And importantly, how are you utilizing this for your clinical practice?
Yeah, so POLARIX study has really been important for frontline DLBCL for quite a few years now. And it was great to see 5-year follow-up data. The study design was quite straightforward. Patients were randomized 1:1. They had to have untreated diffuse large B-cell lymphoma. Important to note that there was an upper limit for age enrollment. It was up to 80 years. And patients needed to have slightly higher risk disease, so IPI score of 2 to 5. And then they either got Polatuzumab and RCHP or R-CHOP, which was standard of care at that time. The primary endpoint was progression-free survival, which is relevant because most patients in diffuse large B-cell lymphoma, at least PFS used to closely mirror overall survival till very recently. The initial analysis, which was 2-year follow-up, showed benefit of polatuzumab RCHP over R-CHOP with a statistically significant hazard ratio, which was maintained in the 5-year update. So how I counsel my patients is that there's about a 5% benefit. So 59.1% 5-year progression-free survival versus 64.9% a 5-year progression-free survival, which is statistically significant. And then we discuss, that 5%, what does that mean? It's clearly not a game changer, but it is an incremental benefit. We have had this debate so many times in oncology, right? Like there is a progression-free survival benefit, but there is not a statistically significant overall survival benefit. So how do you use it in practice? The side effects were very similar between the two groups with no excessive increase of grade 3 or 4 side effects, with the caveat that you have to give growth factors with polar CHP. If you presented it to a patient that you might have a 5% benefit, but the side effects will be the same, most of the patients would want that 5% extra benefit, even if it's not a miraculously different outcome. So I've been very liberal with my use of polar CHP. If a patient has non-GCB or what we call activated B cell type ABC DLBCL, there were at the presentations at ASH, there was an oral presentation by David Germain and Eddie Cliff's group where they showed that the margin of difference in patients who had ABC DLBCL was dramatic between polar CHP and R-CHOP. And that's not because polar CHP did better, it was just that R-CHOP did so much worse. These patients stand to benefit more. So in those patients, I do tend to definitely do polar CHP. In others, it's more of a discussion, but unless they have bad neuropathy to begin with, I think I just favor polar CHP in most patients with a higher IPI score.
Pallavi, thank you for touching on this. We're talking about clinical practice. Clearly, there's PFS, no clear OS. What are you doing based on this data from POLARIX after ASH in your clinic?
Sorry.
No, go ahead, Rohit.
Yeah, so I think it's more of a university setting or what you're used to as well. In our setting, we have been relying on for non-GCB patients, Polar R-CHP, as Pallavi mentioned, but for others, R-CHOP has been our go-to regimen.
Yeah.
Honestly, I feel
True.
this debate around POLARIX will continue.
Yeah, and so if you again, like the thing is, you kind of take subgroup analysis, right? And then if you start following every subgroup analysis, like patients who had an IPI score of 2, the margin of benefit was not statistically significant. I know my colleagues who may just do R-CHOP for IPI 2 and reserve polar chip for IPI 3 to 5. A lot is at the discretion of the treating physician. And of course, it's always a discussion with the patient. But yes, the debate will continue. One thing I would say is when I initially looked at this data, I was like, oh, there's no overall survival benefit. It's getting harder and harder to show an overall survival benefit in diffuse large B-cell lymphoma in the first line setting because we have so many good second line and third line options now.
Indeed.
So, like I mentioned, the study restricted enrollment up to 80. So, how I've been extrapolating this data in people above the age of 80 is that I've been prioritizing. I was just doing it with Polar R mini chip rather than with full dose R-CHOP. And there was a subgroup analysis at ASCO last year where they looked at patients above the age of 70, and the side effect profile was still in favor. I mean, similar between the two regimens. So I don't really use age to make that decision should they get Polar chip or R-CHOP.
Absolutely. And whenever we're talking about POLARIX, the other thing that comes up is this discordance of truly saying if this is GCB versus non-GCB, depending on if you're using NGS to appreciate that versus in the community settings. I would like to believe that discordance is probably higher.